Good day and welcome to the Robert Wood Johnson Foundation Building Health Equity from Resources to Community Action conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Senior Communications Officer Nicole Bronson. Please go ahead, ma'am.
Hello, everyone. Thank you so much for joining us today. And thank you for such a diverse group of participants. We look forward to giving you an opportunity to frame health equity in your work and, as the title indicates, to move from the resources that are out there to actual action. So first I want to introduce our speakers today. My name is Nicole Collins Bronson. I'm a communications officer here at the Foundation. We'll also be hearing today from Tracy Orleans, who's a senior program officer and senior scientist at the Foundation, from Paula Braveman, who's the director of the Center on Social Disparities in Health at UCSF, from Shoshana Spector, who's the executive director of IndyCan, and William Lovett, the executive director of the New Jersey YMCA State Alliance. So a little background before we get started with our speakers, who will each sort of go through their work in this field. The reason for the webinar today really was that we realized this spring that there were so many new resources out there and so many ways that people were sort of thinking about equity, providing new tools. We thought it would be great as a foundation that is in this space to sort of bring us together and talk about the ways we can move from the research and the tools to action so that we're not just sitting here absorbing and not really acting. So on that note, I want to just point out before we get started a new resource we have on our website, which not just for our resources, but for many of yours and other partners of ours. It's called Achieving Health Equity, and it's a toolkit of sorts. And you can see the navigation there that shows you, a little bit about how it would work. This is actually a promotion from our website, the homepage of our website right now. And again, this page is focused on a very, very sort of 101 on what health equity is, some examples from communities doing real work, and then action steps. So I want to talk a little bit about action steps. I'm showing you two here from the toolkit. The first one being a Share Your Story module, where people can literally send this form to me, and it literally comes to me in my email and gives me your story. So we'll be following up with you all. And then the other one is the What You Can Do part of the toolkit, where there are specific action steps everyone can take, not just researchers, not just medical professionals, but policymakers, journalists, educators, parents. So we really encourage you to spread the word on those. And again, the resources here are not just ours. We have CDC, FDA, any Casey Foundation resources referenced here. So if you do see things that you think we should add, please also let me know, and you can put that in your Share Your Story. So the next thing I want to show you is a couple of the things that we have on this site, the kinds of things you'll find on the site. The first is a very influential report that came out in January from the National Academies of Sciences, Engineering, and Medicine, Communities in Action, Pathways to Health Equity. If you do not have this report, please get it. It's actually online, and you can go page by page and search for terms. It's just really the National Academies putting its imprimatur on the concept of health equity and drilling down into communities that are really doing the work and making a difference. The other kind of thing you'll find on this site is the graphic that you see on the right, which is a new graphic that we've developed to help people talk about what equity really means and, for instance, why it's not the same as equality. So again, we will email you after the fact all of the resources we talk about here today, but just so you know, these are the kinds of things you can find on that new web page. So speaking about figuring out what equity is, what our starting point is, and how we can get there, I want to turn it over to my colleague, Tracy Orleans, who will talk about why this definition in this new report matters so much. Tracy.
Well, thank you, Nicole. Until recently, talking about equity as a health researcher in the United States seemed almost radical. But today, the term health equity is mainstream. The number of scientific papers with health equity in the title or text has skyrocketed. Some of this work examines the health effects of racism and other forms of discrimination. Some of it addresses biases in science or policy, and some explicitly mention social justice. It's gratifying to see the broad research agenda developing around health equity. In particular, it's exciting to see that explicit discussions about health equity are occurring across the country among health policy researchers and their funders, and in boardrooms, hearing rooms, community meetings, in print, and online. I'd like to mention, too, that the National Academy of Medicine report, which Nicole just mentioned, is the most referenced downloaded report in the National Academy's history. That is quite an endorsement of the strong interest right now in understanding and addressing health equity. Yet, at the same time, it's clear that health equity means different things to different people. While it's not imperative that everyone define it exactly the same way, having a common understanding of the core elements of health equity is essential for researchers, for advocates, decision makers, and policymakers. The words we use matter. Definitions matter. And clarity is particularly important because pursuing equity often involves engaging diverse audiences and stakeholders, each with their own constituents, beliefs, and agendas. Finally, in an era of big data, a sound definition is crucial to shape the benchmarks against which progress can be measured. So in sum, we've sought a definition of health equity that can help to guide broad national efforts to advance health equity and to measure our progress in achieving it. Thank you, Nicole.
Thank you, Tracy. Now for a little bit more about the definition itself, we will turn to Paula Braveman from UCSF.
Thank you. It's a real pleasure to participate in this webinar. I'm going to talk about highlights from the report that Nicole and Tracy just mentioned on the concept of health equity. The Foundation supported the production of this report initially because of a recognition of the need for common understanding of the term within the Foundation. But then there was the realization that working with others outside the Foundation, it was equally important to have a shared understanding of health equity in order to work together with others to achieve it. I had the privilege of collaborating on this report with Elaine Arkin and Foundation staff Tracy Orleans, who just spoke, and also Dwayne Proctor and Alonzo Plow. Next slide, please. So some of you may be wondering, why get hung up about the definitions? Isn't that a bit academic? I want to underscore something Tracy said. Definitions can matter, and clarity could be particularly important for health equity because pursuing health equity is likely to involve a long uphill struggle that has to engage multiple stakeholders along the way, each with their own agenda. And under those circumstances, if we're unclear about where we're going and why, we can more easily get lost or detoured along the way. Also want to underscore the fact that the goal in this effort was not for everyone to use exactly the same wording to define health equity, but to identify core elements. We wanted to identify a common understanding that helps people sort out what is fair and unfair, just and unjust, and helps them move toward equity. And this required an in-depth look behind the words because people assign very different meaning to different words based on their own values. Next slide, please. The first step was to get clear about guidelines and justification for what's included and what is not. For example, the science-based criterion is crucial to justify concepts that some people may disagree with. The definition had to capture the essence of equity, which is concern about justice. It also had to be concrete and unambiguous enough to guide policy decisions toward greater equity. Definitions that encompass too wide a field open the door for co-optation, and in a minute I'll show you an example of that. We wanted the definition to invoke an important role for the social determinants of health. And although the main audience was in public health, we wanted it to be relevant to the work of people outside the traditional health sector, working in fields that have tremendously powerful effects on health, such as education, childcare, housing, and community development. In addition, the definition had to be useful for guiding measurement, because without measurement, there's no accountability. On top of that, it needed to be clear and compelling to a wide audience. So this was not a very easy set of criteria to meet. Next slide, please. The most compelling definition that I think anyone has ever come up with is a definition of inequity by Margaret Whitehead almost 30 years ago. She defined inequity, health inequity, as health differences that are not only avoidable and unnecessary, but also unfair and unjust. This is very compelling, but the problem with it is that notions of fairness, justice, and even avoidability are highly subjective. For example, in some places, women's lack of civil rights is not considered unfair by those who are in power. Their male relatives should protect their interests. No need for them to have rights. Next slide, please. I want to give you a few other examples of some definitions that we looked at and how we saw them. So health equity is measured by the absence of disparities in health and its determinants. So the definition of health disparities implicitly goes a long way toward defining health equity. This example defines a health disparity as a difference among social groups in the incidence, prevalence, or severity of a particular health outcome. And what's great about this is that it's very measurable. But there is a problem, which is that it doesn't reflect equity. It encompasses all of epidemiology. According to this definition, the fact that skiers are more likely to have fractures than non-skiers would qualify as a health disparity. It puts values under the radar. That may prevent hostile forces from mounting a backlash, and I strongly suspect that that was the motivation for doing this. But it also could be used to starve efforts for equity, scattering the resources. Next slide, please. So let's go to the other extreme now, from a very technical definition devoid of moral content to one that defines health disparities as health differences caused by social injustice. This is very intuitive and compelling. But the problem with it is that the causation of most health outcomes is complex and multifactorial, and often the causes are unknown or they're controversial. That makes it very difficult to prove that a given health difference was caused by social injustice, even when it was. Next slide, please. This definition was adopted by Healthy People 2020 and is used by various HHS agencies. It defines health disparity as a plausibly avoidable, systematic health difference adversely affecting a socially disadvantaged group. What's great about this is that it is very tight conceptually and technically. It's also explicit about social disadvantage and therefore implicitly about justice. In addition, social disadvantage can be measured, for example, by wealth, by income or education, by someone's race or ethnic group, by their disability status, their sexual orientation, or their gender identity. Social disadvantage can be measured by who's in power, looking, for example, at how the extent to which a group is represented among those in high political or executive office, looking at whether a group has historically and systematically suffered discrimination, for example, slavery, expropriation from ancestral lands, denial of voting rights, hate crimes, disparaging slurs and stereotypes in media. All of these are measurable. But the downside of this definition, we felt, was that it is complex and it's not very intuitive or compelling to a wide audience. In addition, it's not explicit about social determinants. So next slide, please. So what did we come up with? So informed by the strengths and the weaknesses of previous definitions, we tried to craft something to meet the criteria that I mentioned earlier. It is not perfect. We expect it to evolve with more input. It has two parts. So the first and main part you're looking at now. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. So among the strengths of this definition are that it includes everyone while still being explicit about the need to address poverty and discrimination. And when we use the word discrimination, we're not just talking about race-based discrimination. That's a very important form of it, but there are the other domains of discrimination that I mentioned earlier. It's also explicit about the need to address powerlessness and living and working conditions. So it implicitly narrows the interpretation of fair and just. It strongly highlights the social determinants of health. It is concrete and it's actionable. But its chief weakness is that it is not clearly measurable in the way that the Healthy People 2020 definition is. So next slide, please. So because of that, we added the following. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. So next slide, please. This diagram reflects the conceptual framework underlying the definition that I just showed you. I don't have time to discuss it now, but it is discussed in the report on the RWJF website. I'll just point out a couple of things in it that I think help to explain important aspects of the definition. One is that opportunities to be healthy depend on the living and working conditions and the other resources that enable people to be as healthy as possible. Another is that achieving health equity requires actions to increase opportunities to be healthy, and this requires removing obstacles and improving access to the conditions and resources that strongly influence health, particularly for those who lack access and have worse health. And finally, these concepts put social factors front and center in health equity. If we take them seriously, they mean that to advance health equity, we in the health sector must ally with those in the non-health social sectors that shape health. So equity in healthcare is crucial, but it is not enough to achieve equity in health. Thank you. I'll look forward to the Q&A.
Thank you so much, Paula. And just a little housekeeping before we move on to our next speaker. A lot of you were asking questions about the presentation and whether it will be available online afterward. The answer is yes. We will have the whole presentation available for download, and all of the references and resources that we talk about in the webinar, we are actually going to email you after, as soon as we stop the webinar. So you will have all of that information. I want to just point out that you can actually ask questions now if you like in advance using your chat function. We will, after our next two speakers, we will take about 10-15 minutes to go through those, so you can ask them now and we'll queue them up for later. So with that, I'd like to move to the action piece. We've talked about the references and resources, so we're going to move to action in the communities with Shoshana Spector, who's the Executive Director of IndyCan.
Hello, everybody. My name is Shoshana Spector. I'm the Executive Director of IndyCan. We're a catalyst for marginalized people and faith communities to act collectively for racial and economic justice, a part of the PICO National Network. And we start our work every year having conversations with thousands of people at kitchen tables and coffee shops and church basements to really understand what their vision of the community is for what it would take to create healthy life. And one of the people that we met a few years ago, his name is Tim Vaughn, and Tim, he started the fight for transit expansion in Indianapolis. After 20 years of failed attempts, IndyCan catapulted transit enabling legislation across the finish line in a conservative state house and set up a once-in-a-decade shot to win at the ballot box a transit initiative that would triple access to good jobs. Tim goes to Christian Love Missionary Baptist Church. He's a husband and father of two little girls. Look at them right there. Aren't they so cute? But every day he gets up at 3:30 in the morning for a job at the mall that starts at 7 a.m. Castleton Mall is at 96th Street, but the bus only goes to 80th. That means rain, snow, freezing wind. Tim has to walk over an hour each way to get to work after he already spent an hour on the bus. This means that Tim's away from home for 14 hours, even though he only gets paid for 8. He's not there to tuck in his babies at night, to help them with their homework, to prepare a healthy family dinner, And all this for a job that just pays over minimum wage. So for Tim, a good bus system in Indianapolis is the difference between going hungry or feeding his family. And he tells me it really defines what kind of father he can be. And Tim is one of hundreds of people that we talked to in 2012 who told us, there are so many things I would want to do with my life, but I just can't get there on the bus. And so in Indiana, we believe in putting families first, in pulling together in hard times, sharing God's abundance so that everyone can lead a healthier life. Yet the reality in our city is that opportunity and well-being is segregated. A trip that would take 15 minutes in a car, like to the Castleton Mall, takes 3 hours on the bus, leaving families, seniors, and children, particularly in communities of color, isolated from good jobs and healthy food and the doctor's office. This map is a study we commissioned from the Kirwan Institute a few years ago that maps the bus routes, the lines in blue, with the job locations, the purple dots, and looked at race and poverty. And what you can see from the map that's not clear is that where poor people of color live, there are very small dots. There are no dots, meaning no jobs. And where the big purple dots are, where all the jobs are very far away from any transit stops. So communities of color are isolated from good jobs, healthy food, the doctor's office. Half of Indy's children go to bed hungry because despite adding 5,000 new manufacturing jobs to the region each month, workers can't get there. In Charlotte, North Carolina, transit riders are 81% less likely to become obese over time. And in study after study, stronger transit systems are linked with fewer incidents of chronic health problems. According to Harvard, transit access is the single strongest factor in the odds of escaping poverty. Yet it's deeply racialized. As you can see, 1 in 9 blacks compared to 1 in 33 whites depend on public transit to get to work. So we understand that investing in public transit is a way to make Indianapolis a fairer city and one that works for everyone. That if we invest in transit, we include neighborhoods so more people can get to work, to school, and provide for their families. That really transit is the ticket to opportunity and well-being. So in 2016, this last election, after hard work from people like Tim, we were able to get the state and the city council to put forward a transit measure that we would vote on by the public that would set up a $1.3 billion expansion to triple access to jobs for communities of color, generate 47,000 jobs, and create an engine for racial and equity and healthy communities. So despite anti-tax conservative opposition, which was very strong, we knew it couldn't just win, but it had to win big. And I just want to share 4 things that we felt were critical to winning. One was race at the center. So in the age of dog whistle politics and implicit bias and a politics that exploits racial anxiety for political gain, ignoring race is not an option. The task is to put race at the center in a way that bridges difference and invites everyone, whether they ride the bus or not, to be a part of transforming our city. The second was credible messengers. So bus riders and multi-faith clergy were at the center of this fight. In the 16th most church state in the nation, and all the polling and our experience shows that when trusted messengers, neighbors talking to neighbors, bus riders who are impacted, and clergy who hold significant moral authority are the public voice, people respond. And third, that we have to get out and talk to people. Our strategy focused on people who are traditionally left out of campaigns and political parties, African Americans, the poor, youth, people that ride the bus, and a set of persuasion white voters, that we went out and talked to 40,000 people. So we would have to have conversations with our community. And finally, a united coalition. So we brought together 120 organizations, including the Chamber of Commerce, labor, churches, that participated in some way in this fight. So based on that theory, in the 12 weeks leading up to Election Day last year, 14,000 IndyCan leaders made 164,000 phone calls, talked to over 40,000 people. And in the pews, in the homes, at the polls, 80 clergy were trained, reached over 75,000 people in preaching and teaching to amplify this message of transit equity, earned 38 media stories, and lifted up the human dignity of bus riders and the moral imperative for transit equity. And we made sure that decision makers were directly accountable to the community at the State House, at the City Council, and at the implementation table. So the results of that work on Election Day, November, even in a state that voted double digits for Trump, we passed a tax measure leading with a racial equity message by 20 points. That's going to pump $56 million a year into public transit, tripling job access for communities of color, generating 47,000 jobs. And we got a commitment from the Indigo, the bus operator in the city, to be the first agency that would develop a formula to ensure that people in the highest poverty neighborhoods and folks that have significant barriers to employment, like a felony, would be the first ones in line for these jobs. So now, in the next 3 years, as this builds up, instead of waiting an hour for the bus, there will be a bus every 7 minutes, all 7 days a week, getting people all over the county. And really, we believe that this is going to be a critical moment in shifting people's access to jobs, to health, to the doctor's appointment. It really is the ticket to opportunity. But we also know that our work is not over. So to keep this on track requires federal matching grants, equitable implementation, and other counties across Marion and Indianapolis to follow suit. And there's just a couple lessons I want to lift up. So one is that you can lead with a racial equity message and win, and in fact, you can't win without it. That it's critically important to talk about disparity in a way that brings a multiracial coalition together to make a city or a region where everyone thrives. That the power that we built investing in the community and making sure that community leaders were at the center of this fight means that this power will not go away. So in contrast to many efforts to change the community by outside consultants and people that come in for a short amount of time, the power and the relationships that developed through this campaign will stay long after Election Day. And we learned that when you give the community a choice to stand up for their neighbor, to vote for fairness, to believe that everybody matters, people stand up and they vote for inclusion. So I just want to share a quick 2-minute video of some of the highlights of the last 2 years in making this happen in Indianapolis. And if there's someone on the call that knows how to press that button, please help me out.
Shoshana, I think we're actually going to have to, for time reasons, I think we're going to have to actually email that video to people after the fact.
No problem.
But we will do that so you all can see that, because this is a fabulous story and just a fantastic example of the community really driving change. We will now go over a few states, back to New Jersey, which is the Foundation's home state, and hear about some of what the New Jersey YMCA State Alliance is doing. Bill Levitt, the Executive Director, will now do his presentation.
Well, thank you very much, and it's great to be with you guys. And I have to start off by saying that I don't know how many people are in it, but I'm now in the Shoshana Spector fan club. That is just fantastic work. I think if we could all applaud and you could hear it on the phone, you would have just heard it. That really gets me fired up. And so it's great to be with you all, and I get excited also because there are so many people that are on the call. It says that we really are beginning to build a social movement around the importance of looking at so many factors through the lens of health equity. I run the New Jersey State Alliance, which has 37 YMCAs in it and 600,000 members, and we look for ways to align ourselves on a state level to impact scalable social change. And so since 2009, we've had an incredible relationship with the Robert Wood Johnson Foundation, and it began with a program called the New Jersey Partnership for Healthy Kids, where we took 5 communities in New Jersey and began working with them. And that's New Brunswick, Newark, Trenton, Camden, and Vineland. And so what I'll try and do is just give you a sense of the kind of things that we're working on, and just sort of go down the list that you see on the screen. So we started with these 5 communities, and I'll give the foundation credit because as we worked with them to finalize these 5, it was really through a health equity lens that these are 5 urban New Jersey communities that are significantly challenged, and that over the last 8 years we have really made incredible progress working with homegrown leadership in those communities. And that's one of the reasons I love that Indianapolis presentation, because I got some stuff out of that that I think applies also to some of our work here in New Jersey. And so we began with those 5 communities 8 years ago, and we began thinking about how is it that we can move the needle forward in a more scalable sense, because we see ourselves with this work as conveners, connectors, and innovators, and also we try and see ourselves as viewing, looking at health equity as the lens with which we really take a look at what matters to us and what we want to spend time on. And so we decided that after having a lot of success in those 5 communities, we would launch a program that was called the New Jersey Healthy Community Network. And we brought together 6 funders, and at this point we have 42 communities that are doing policy and environmental change and receiving technical assistance from us throughout the state using a policy and environmental change platform, and that the solutions and strategies are locally developed and implemented. So one of the sort of neat things for us now is that we sort of feel like we're on the path to something that is, we're really trying to move the entire state. This could be a strategy that not only I think could impact New Jersey, but that other states could look at. Because the exciting thing for us is we're just finishing a 2-year grant cycle with these 42 communities, and we're getting ready in January to start another grant cycle, and we already know that we're going to jump upwards of 70 because we have other funders coming on. So we'll see how far we can take it. But throughout New Jersey, we are seeing some real progress. Of real interest also is the Healthy Corner Store Initiative. And this is one I think that really hits home for those of us that are looking upstream around health equity issues. In Camden, which is one of our core communities, there are 60,000 people that live there. There's one supermarket for that entire community, and that supermarket's not easily accessible from a transportation point of view. So the reality is the food distribution system in Camden is through corner stores, and that's true in many, many New Jersey communities. So we decided that we would really try and form a network of healthy corner stores. And so thanks for someone for clicking the map on me. That shows you sort of throughout New Jersey where we've got a number of clusters of healthy corner stores that are doing work. So again, you can see where our emphasis is to try and come up with strategies and then see if they're scalable and we can drive community change. One of the things I thought you'd find interesting is we have Montclair State University doing external evaluation for us around what does it take to create community change. And so these are the 6 things that the research is showing are critical. And not every coalition that we work with has all 6. And in fact, it'd be rare, I would think, if they were getting A+ on all of them. But it does help to create a framework, whereas we're working with communities and you're looking at this and maybe doing work locally yourselves. This is what gives us, I think, a pathway to say if we really want to achieve maximum impact, we should be looking at these factors. Part of our work in New Jersey has been around trying to bring different partners to the table, and so this is sort of interesting because we have a wide variety of different partners that are significantly engaged with us. And those range from an organization called New Jersey Health Initiatives at the top, which is a program of the Robert Wood Johnson Foundation that does statewide work. Next to that is the New Jersey Department of Health. Campbell Soup, Novo Nordisk, and Johnson & Johnson are all major corporate players in New Jersey. And Horizon is the leading health insurer in the state with nearly 4 million people insured, almost half of New Jersey. So we have worked with all these entities and tried to find where the sweet spot was in their interests, some of which are statewide, some of which, such as Campbell's, is local in Camden. Novo Nordisk has been doing a lot of work in Trenton for us. But we're really excited about the fact that more and more significant funders, at least in New Jersey, are starting to understand that we need to go upstream and look at what is going on in a community and be willing to look at those preventative changes, policies, and environmental changes that really would matter. So as we think to the future in New Jersey, this is sort of where we're hanging our hat. And we're going to be spending a lot of time around trying to impact our healthy schools, food access and physical activity remain important, creating healthy communities. I've been speaking a lot about that. Health equity is on the left, and again, if I had to do this diagram differently, I would have had that sort of ooze over everything, because that's sort of the filter with which we're trying to evaluate our work. And the last thing I would mention, and I'm going to be wearing my YMCA hat as I say this, because the New Jersey Partnership for Healthy Kids is funded by RWJF, and so we do not do lobbying with foundation money. But wearing my YMCA hat, but tied into this work, is that we lead a coalition of not-for-profits in New Jersey that are concerned and interested in health prevention and population health issues. And so that group we serve as the lead convener for has had significant success in New Jersey in helping to drive legislation forward and to drive policy development forward that improves the state. So very much appreciate the chance to speak to you. There's a link down below that you'll get via email that there's a really interesting 5-minute video that sort of tries to put faces to our work. Encourage you to watch that, and very much look forward to the question and answer session, and thank you very much.
Thank you, Bill, and thank you for bringing your other hat, because we only have one here at the Foundation. So we're actually going to move into our Q&A section. I want to remind you that we will have the webinar recorded and downloadable from our website after the presentation today. We will also email all of you a list of the resources we mentioned today and the videos that Shoshana and Bill talked about. So we'll start, first of all, I would say use your chat function and raise your hand online if you have any problems with that, and we can help. So we will start with a question actually for Shoshana. Besides transit, can you talk briefly about other areas that IndyCan is focusing on to continue to advance health equity in your community? What are your next priorities?
Absolutely. Directly related to health is the challenge, the biggest health crisis in our country right now is mass incarceration of people of color. So in our city, 60% of the people that are sitting in county jail have a diagnosed mental health issue. 90% of the people in our jail are addicted to substance abuse, and we believe that that should be met with treatment, not incarceration. So last year we led a campaign educating our city council and the mayor and other decision makers to vote down a proposal to expand our jail system and add 5,000 extra beds, and instead move that money to investing in treatment and jobs and strategies that divert people who really need treatment, not incarceration, to create more opportunity and health equity. That's just one example.
Yes, thank you. That's great. Our next question is for Paula. We used to hear more talk about health disparities. Now, health equity seems to be more in the spotlight. When we focus on health equity, are we abandoning work on health disparities? How are disparities and equity related, if they are?
Well, that's a great question, and I think it's an important one. I think there have been some changes in thinking since the days when people were using disparities, but you didn't hear equity so much. So the initial focus of the work on health disparities was on racial and ethnic disparities in health care. And that definitely broadened considerably at a certain point to include both the racial and ethnic disparities, which are terribly important, but also socioeconomic disparities, disparities by disability status, LGBTQ status, gender, religion, etc. But for many people, the association, when you say disparities, the association with race, ethnicity persists. And I think that's one of the reasons that some people have welcomed the new term. In addition, that initial focus was heavily on health care was disparities in health care that were the initial focus. That also broadened to include health itself, but as with the focus on racial and ethnic disparities, the association with health care still persists for many people. So by contrast, the term equity implies that there are multiple dimensions involved: race, ethnicity, religion, socioeconomic status, disability, LGBTQ status, et cetera. And that's, I think, one of the advantages of the term equity. The term equity also implies that we consider health status and its determinants, of which healthcare is only one. Healthcare is a very important determinant of health, but it's only one, and both Shoshana and Bill have spoken very eloquently about some of the other very powerful determinants of health that should come into play when people think about health equity. In addition, and related to that, the use of the term equity tends to imply consideration of the social determinants of health, the factors apart from health care that strongly influence health, like transportation and like criminal justice policies, like child care, education, et cetera. So finally, I think that the term equity is very explicit in that it's about values. It means fairness and justice. Using the term equity invokes values that both, and I think that it's both ethical and human rights principles. And those principles have often been implicit during the era in which there was more focus on disparities and we weren't hearing about equity. So if somebody is assuming that what I'm saying means that equities in and disparities are out, absolutely not. We need both of those concepts and both of those terms. It's only by measuring disparities in health and its determinants that we can measure health equity at all. So I think we need to see them as a set, and more people are using the term disparities to invoke not only disparities in health care, but disparities in health status and a broad range of its determinants, and to invoke disparities that go across multiple dimensions of social disadvantage, including but not limited to racial.
Thank you, Paula. That's a really important distinction. I want to remind everyone, too, that Paula's report is actually on the Foundation's website, rwjf.org, and will also be in the email that you get after the presentation. So our next question is for Bill. Can you share the 6 factors that lead to successful community change? The slide went by too quickly. We can back that up so people can see it again.
I'm on my way. Oops, I went too far. So, yeah, so these are the 6 factors, and we'll be sending them to you. And the one I actually would reference well, there's 2 I'm going to just highlight. One is, and Shoshana, I think, did a great job with this, is that we see the greatest progress when there's a committed, mission-driven program champion, that there is someone that just is not going to let go of this and is absolutely committed. And the other piece is when you link someone like that with, on the far right, municipal government support, that combination can really drive significant change. Not that the others aren't important, but those 2 I would just really want to lift up. But there's the 6 on the screen, and you could probably think of some others, but those are the 6 that our research says are the most important factors.
Great, thank you, Bill. And we'll just leave that there for folks to take a look at. The next question is back to Shoshana. For a business that is not necessarily directly in the community or cannot start a large initiative in the community themselves, but work with clients that are or can, how does this company achieve health equity themselves and with their clients?
Well, I think that's part of why we started a coalition table. So we built a partnership of 120 plus organizations, some of them service providers, some of them the Chamber of Commerce. But as Bill has on his list, diverse partnerships working toward a common goal, it's that you can unite with other people in your community that have a similar vision to move forward together. And we believe that actually is part of the secret sauce in leveraging change.
Thank you. Next one is for Paula. Is everyone in the academic community on board with the definition of health equity? How about also politicians and other stakeholders?
Well, that's a great question. I think that if you interviewed people in academia, who do work in related fields and asked them how they define health equity, if you interviewed 100 of them, you'd have 100 different definitions. We just put this definition out there. I think it's only been up on the website just for a week. We'll see what the reactions are to it. It's too early to tell. What I suspect is that people will hold on. I mean, there are many definitions, and many of them have some wonderful strengths, and that we shouldn't use that. If talking about this definition, though, prompts discussion, not just in academia, but among policymakers as well, some discussion and being thoughtful and explicit about what health equity means, I think we'll feel that this has served its purpose, that we won't judge the success of this work by whether everybody's using the Robert Wood Johnson Foundation definition, although, of course, we hope that some will.
Yes, I do. I know I do. So this question is actually for everyone. We'll start with Shoshana. It seems reasonable to assume that all of us on this webinar view health equity as an important priority, value, and goal. Do Shoshana or any of the other presenters have insights they can share about the challenge of engaging with or even persuading Americans who don't necessarily share this assumption?
I think that the key to that is really about building relationship. That most of us, I'll speak for Indiana, that we have some shared values. We care about taking care of our neighbor. We care about creating a community where everybody thrives. And so part of our work before we launched the campaign, we spent 4 months having house meetings and congregational events, just having people share their story about how hard it is for them to get to the bus. Because the reality is that the majority of people that voted for transit didn't take the bus. That most people had to be moved, that they would stand up for their neighbor and, vote for a tax that would be really in the interest of the common good. So I think that the work of community organizing and building bridges across difference is really about getting people in relationship with each other, sharing stories, and then amplifying that across the community. So I would say that there isn't anyone who can't be persuaded. And in fact, we did initial polling, and the most effective messenger was clergy. That when people saw multi-faith, multiracial clergy working together because they believed it was in the common good, that was the most significant thing that moves people from opposition to support.
Wow, that's fantastic. Bill, did you have any thoughts on that?
Yeah, I did. Thanks. So I really think we're onto something when we talk about fairness because, for example, if I'm talking to someone about a county in New Jersey where 8 miles apart with different zip codes, there are 5 to 8 years difference in life expectancies. And then if I were to then overlay that with access to healthy food and access to physical activity and show that the ability of people with the lower life expectancy is really being impacted by their ability to get healthy food to their family, then the reaction I get is someone says, well, that's not fair, and that people deserve a fair shot. And so as we think about equity, I think when we talk about fairness and to give everyone a fair shot at a healthy and fulfilling life, and that we need to remove those barriers that have been placed either historically or by policy, we need to remove those barriers. I think that resonates with people because that sort of taps into a fundamental value that I think all Americans hold.
I couldn't agree more, Bill. I think the Americanness of that value is sort of something that we talk about a lot at the Foundation too. And actually a follow-up question for you about the Corner Stores project. Did you look at working with the stores to provide healthier food choices, moving chips and sodas to the back, for example, and fresh fruits and vegetables more visible when and available?
Yeah, so corner stores are sort of interesting. So I'll just say a couple words on it. So, most of the corner store owners are all locally. A lot of them live right over their store. They're in the community. So in general, we find that the people who own these stores need to make a living. They are adverse at times to risk because their margin's small, but they care about what's going on. And so there are sort of three things that we really try and work on with those corner stores. One is linkage to providers. That might sound simple, but we've got to be able to show them a way that gets the fresh fruits and vegetables to their store. Second is we need to help them with how to present those fruits and vegetables, and at times that means buying them refrigeration equipment. And then third, a lot of times we work with them on how to present and package those. And just one easy example is a corner store owner had fresh fruits and vegetables next to a school, and they really weren't doing well with the sales. But when he took the cantaloupe and the strawberries and he cut them up into fruit cups and sold the cups, they sold like crazy because kids could take the cup, grab it with their fork, and go off and eat on the way to school. So if we can show them that there's a sustainable business opportunity that does good for the community, that's when we get success, and so that's what we're trying to do.
That's great. We're going to do one last question, and we'll actually, I'm going to throw it to Paula first so we can wrap this up. The emphasis on disparities and determinants has led some folks to a certain fatalism, i.e. not being able to achieve health equality was the question, of health outcomes until we entirely eliminate poverty and social injustice. So how do we celebrate communities that are making progress and create an affirmative expectation that health equity and specifically equality of health outcomes is achievable?
This is very, very important, and I think that what we need to be talking in terms of embarking on a path toward greater health equity, and that's why you may have noticed some of the words that I chose were in talking about disparities, reducing and ultimately eliminating disparities. Not saying just eliminating disparities, because sometimes that seems too overwhelming to people, and to some people it seems that that's just impossible. So I think that the answer is that we think about it in terms of embarking on a journey, and that the goal is to be pointed in the right direction, in a direction toward health equity. Some people have talked about health equity more as a process than as an outcome, and I think that's why. I think that the concept that question is getting at is why some people have felt that it's important to think of it as a process, embarking on a path toward greater equality of opportunity and toward equal opportunities to be healthy for everyone, and that it's not just the ultimate endpoint, which we know we're not going to achieve short term. That's for sure.
Mm-hmm. Thank you, Paula. Shoshana, do you have any thoughts on that score?
Well, I just think that it's important to remember that in our communities we're conditioned to believe that people of color particularly, their suffering is normal. And health equity, it's pretty simple. If people have access to good jobs, if people have access to healthy food, to communities that build their health and well-being, then the health indicators become more equitable. So I think that part of our work is to continue to fight for systems that create equity for everybody, and that it is very achievable. It really has to do with what choices we make about how we set up our communities.
Great. Thank you so much. Bill, any final thoughts?
It's sort of interesting. Well, great discussion. I think that part of what we want to do is to give our communities a sense of hope and the possible, and that when they begin to achieve success and see that they can make change, it lifts everyone up. And so in Trenton, for example, we opened a farmer's market 2 years ago. It was the first farmer's market in Trenton's history. And the excitement that we saw in the community, that they had been able to successfully implement and sustain that, then helps to move others forward in other areas. And I'll finish with this thought, which is, and I'm going to sort of circle back to some of what Shoshana was saying, is that I heard a speaker once say that systems change requires relationship change. And our ability to bring people together that may not know each other, and that over time those relationships evolve and strengthen, and you begin to create the kind of sense of purpose and sense of trust that can move a group forward and move a community forward. And that's not a short-term process, but I think as we think about the last, I was a political science and history major. I sort of think about the past 100 or 150 years, and I see this slow and at times uneven march towards progress in our society, and we have some bumps along the way, but I think that that we will continue to progress forward, and some of that progress may occur on a national level, and some will occur on a local community level, and that to me is really exciting to see that develop.
Thank you, Bill. Those are great ending words there. So I want to thank everyone today for joining us for this discussion. We really hope that you came away with it with some new tools and resources, and also a sense of the work that's happening out there on the ground in communities, and that maybe there are some people you didn't know about who you can now get in touch with. We want to remind you that we have this new page on the website. We'd love to hear your story. Talk about what inspires you, what successes are you seeing, what does health equity look like. Go to this new page. It has a nice, easy link for you there. You can also, and I see many of you have been doing this on Twitter during the presentation, the Twitter hashtag is Promote Health Equity. We'd love to hear stories there too. And of course, please pass along the word, and we hope to talk to you again in a future presentation.
This concludes today's call. Thank you for your participation. You may now disconnect.